Okay, well, here we are again, Marion. Thank you very much for spending another Sunday evening with us. I'm hoping we are now live. I'm just waiting for confirmation from one of my colleagues. We're really not very professional at this. This is all new to all of us.
Well, that's better. It's a little bit, make it interesting.
Absolutely. So you were saying earlier you were in Russia. What was it a holiday or?
Oh yeah, I wish. The first 3 days was Russian families of SMA. So we were seeing all SMA in Ekaterinburg. And then the second 3 days in Moscow, they've got a hospice. It's not residential, and it's almost like an evaluation and assessment center for all disorders. But I was seeing all sorts of neuromuscular disorders, but we were seeing SMA as well.
Awesome. Awesome. Right, well, I think we are good to go. So I believe the topic today is exercises. As normal, if you've got any questions, then please ping them either through Facebook Live or contact me directly, and we'll pass them on to Marion. And over to you.
Okay, good evening from the back end of Harrow near London. I am going to talk tonight about exercise. This is from teeny babies all the way up to adults. We will talk about exercise in relation to what is easy to do, what you should be doing, what you should be avoiding. I will stop every so often for questions. I also have little bits of equipment with me today. So we'll be looking at how basically everything that you can find around the house could be made into exercise equipment. One of the things that we talked about last time was contractures, how you get them, where you get them, and exercise is related quite definitely to contractures, because the muscles that you need to be exercising mostly are the ones that avoid contractures. One of the big mistakes that people make, particularly when they don't have experience of SMA, is to work muscles that are already strong. And one of the things we talked about was muscle imbalance, that you have some muscles that are much stronger than others and pull one way and cause contractures. Obviously, working weak muscle is much harder. The whole point is they are weak. In SMA, you can exercise. This is not going to damage muscle. It's as simple as that. Exercise helps. Regular exercise helps. Exercise that is done by the baby, the person, the child, whoever. But again, if it's done to you or for you, if it's passive exercise, if it's machines, it's not going to work as well as anything you're doing yourself. Now, for exercise to be effective, it has to be aerobic. In other words, you have to feel the work. It's not good enough just to do some exercise and think, right, done it. You have to get a little bit warmer, a little bit breathless. In other words, out of breath. And that can happen in any situation. Don't think that because you're not running, you cannot be out of breath. And you should also have a small increase in heart rate. And I'm not talking about thump thump, like your heart wants to jump out of your chest. But those three effects are aerobic exercise, and that's what we're aiming for in anything that we do. It's not really that just a little bit here, a little bit there. It's the old story. Walking, if you're ambulant, if it's not hard, if it's not faster than normal, if it's just a stroll, it's not exercise. So writing, doing things that you do every day, it's not exercise unless you can feel that you have to put some effort in. So we need to exercise everything. We need to exercise to counteract contractures. We need to exercise to maintain or build muscle. Now, one of the aspects of trying to exercise is that if your muscle is fibrosed, if it's very contracted, can it exercise? Can it do anything? Can it move? It's really important to understand there are many, many different forms of exercise. Exercise does not always produce movement. This is an important concept. There is something called static exercise, which is when you're working really hard but no movement is seen. Imagine you're lying on your bed, flat on your back, and you're pushing your head into the pillow. And it's not going to make a big movement, but if you do it really hard, it's working all your neck muscles and your shoulders as well. It's the idea, we may have mentioned last time, of trying to push a broken down bus. You can push as hard as you like. You're not going to move it very far, but you will still do a lot of work. That is static exercise. And static exercise is really important. It's a good basis to start if you've got no movement, either because of the weakness or because of contractures. And most of what we're achieving in SMA is working on disuse atrophy, the muscles that are weak because they've not been used, not because they've got disease or damage or contractures. In every muscle, there is an enormous number of fibers, and not all of them are going to work hard in the exercise. Not all of them are going to be able to work hard. Obviously, the more severe the type of SMA, the less muscle fibers that are working, but no one, however weak, except the very, very weakest 1As, cannot do exercise. Now, we know that these infants who are severely weak even have trouble on occasions lifting their eyelids, moving their head, wiggling their fingers and toes. So in that situation, you're not going to see big movements, you're not going to see big changes. That doesn't mean to say you can't help them move, you can't move for them. So what are we doing when we exercise? We are giving the muscle resistance. Resistance is what builds power. Now, resistance can be body weight, it can be the weight of gravity, it can be anything that causes some sort of friction. It can literally be friction against air, friction against the bed, anything that makes muscle work and makes muscle work relatively hard. Now we have to split exercise in two direct groups. Those exercises that build power and those exercises that build stamina. So what we're looking at with power is high weight, low repetition, or high resistance, low repetition. And what we're looking at with stamina is low weight, high repetition. And on the whole, that is the sort of exercise we're trying to get for SMA. The low resistance, high repetition. Some of the SMA3s, the stronger SMA3s, can go really out for power. But generally, the exercise that we encourage is low weight, high repetition, because apart from anything, it's less fatiguing. And fatigue is an issue in SMA. Even in the weakest type 1, we have to appreciate the effects of fatigue. When we are even assessing the children, we have to appreciate fatigue and speed of movement. You cannot rush these movements, and you cannot, in some cases, keep going over and over again. You have to appreciate that when you can see fatigue starting, that's the time to stop and have a rest. Now, Andy, I don't know if we've got any questions so far, whether we want to stop quite that quickly or whether we should go on.
I've got one question coming from Kirsty and Neil Carney. Can SMA patients actually build muscle, or is it merely to maintain what they already have?
No, we have seen increases in power, but it really depends where you're starting from. Obviously, in type 3, where there is more active muscle, you will be able to build more power, and in the weaker children, you will build less power. But that is relative. What you have to remember is your starting point. So if you're starting from very, very low power, whether you're a type 2 or a type 1, a very small increase could be 10% of what you've got. And the same 10% in a type 3 or a stronger type 2 may look bigger, much, much bigger. It may be the difference between having to pull yourself up the stairs on a rail or being able to do it without pulling yourself. May be the same as a type 1 just being able to lift their arm. It doesn't look as impressive, but it may still be 10% improvement in the power that they've already got.
Okay, great. Thank you for that. Shall we crack on?
Sorry? We got any more? Go on.
No, let's crack on for now.
Okay. So what are we going to do in terms of what is exercise? Let's go back to what we were talking about last time, and that's the concept that how much, how often, where do we do all this in the context of life in general? So first things, we truly believe in our team, play is exercise. And again, we do not give out specific exercise programs unless there is a definite reason. So if certainly young adults, teenagers, older adults will ask for specific exercise programs, or we will do programs to target particular muscle groups if that is a problem. Now, what we have to consider is the muscle groups that we're targeting, the play that we want to do, and how we make it happen. When do we do it? Every day. Like contractures, exercise has to be every day. There are varying websites from different governments, different agencies, different health boards that will tell you how much exercise you should do, ranging from 30 minutes a day of a certain level of exercise up to 60 minutes. Some will say do 30 minutes intensive. Some will say do 60 less intensive. Ultimately, it is something every day. On that basis, we want everybody doing, and that's parents, carers, siblings, everybody should be doing that level of exercise every day. If it means walking to school, if it means pushing your wheelchair, if it means doing a bit of rolling around more than you've been doing, if it means at nappy change you do a roll as well, or you try and help with sitting up, that is exercise. It is really important, particularly for parents, to appreciate every time you do something for your child that they could have done themselves, or they certainly could have assisted doing themselves, like getting to sitting, like from sitting to lying, like pushing a wheelchair. Every time you do it for them, you are taking away an opportunity to do some of that exercise. If you're going to have to do 30 to 60 minutes every day, it needs to be built into the day. It's not enough to think, oh, how awful, I have to do 30 minutes of exercise, or my child has to do 30 minutes of exercise, when you have already taken away 2 or 3 opportunities for them to have done it somewhere during the day. Like, as I say, getting from lying to sitting, somehow helping with dressing, doing a bit of pushing of their wheelchair. All these opportunities to do something for themselves may well be taken away. So what is exercise? Anything. We can do games. We can play with games. We can do more active exercise, but it doesn't have to be hard. If we're going to use weights, what sort of weights? How heavy are the weights going to be? Now, this is a wrist weight. It's actually really quite heavy at 500 grams, but if you have an older child or an adult who can manage just to do some daily activity with a wrist weight on, then you're going to get that extra resistance for your arms or even your ankles. Now, it may be that these wrist weights don't fit over your feet. It may be that 500 grams is too much. So then somebody has to be a little bit inventive. A pair of tights cut up with some rice to whichever weight you want and then tied up can make a perfectly good wrist weight. So you can make wrist and ankle weights. And the beauty of ankle weights is if you're sitting in a wheelchair, like with TheraBand, which I've also got here to show you, you cannot say, oh, well, I didn't have the opportunity, because merely lifting your leg up is an exercise. Merely lifting your arm up with a weight on is an exercise. So you can make excuses or you can make an effort. It's not up to me to tell you what you must do. You have to take responsibility for your exercise, your child's exercise, whatever you want to do. Having said that, parents, you should be exercising too. Spouses, you should be exercising too. There is no excuse for any of us not doing exercise. It's good for all of us. I appreciate there are active families and there are less active families. There are low motivated children and there are electronic children who spend all day on an iPad, on a phone, on an Xbox, who actually are doing incredibly little. I can't say that's wrong. You have to make your own mind up. But if you don't exercise, 3 things are going to happen. You will get weaker from disuse atrophy, and weakness leads to contractures, so your contractures will get worse. Generally, your circulation, all your organs are not going to get a nice blood supply, your metabolism, everything is not as good without exercise. And the third thing is, drugs that make you stronger all work better with exercise. You cannot just pump these things in and think you're going to suddenly develop muscles all over the place. They do make you stronger, but it is definitely true. The more you do, the more you will benefit from them. We need to consider contractures. If we know from last time that the places that get contractures are the hip flexors, the knee flexors, the foot plantar flexors, those that point down, the forearms, turning palms up becomes difficult, elbows can get tight, jaws can get tight, necks can get tight, backs can get tight. They all need exercising to a different degree. Exercise takes many forms. Let's start with the bad, because that's in a way almost easier than starting with the good. There is a trend at the moment to suspend small children, particularly the type 1, in harnesses, let them dangle and look at their walking, be it on treadmills or on the floor, in these standing harnesses, and what they are using is their hip flexors. We have seen a few children already who are getting tighter and tighter hips from using these machines because they are not weight bearing, they're not using their hamstrings in the correct way, they're not using hip extension, they are merely scooting in these slings. So please beware, both adults, teenagers, children and infants, if you're using standing slings to walk, you are weight bearing, you are using your butt muscles, you can feel yourself trying to get taller and stand up straight. But if you're merely dangling and scooting, you are not having a good effect. Bad exercise number 1. For the ambulant type 3s, one of our unfavorite activities is scooting. Now, I'm sorry, a lot of parents use the scooters for the children because it's an easier way to get around than a bicycle. I accept that. But when you scoot, you only ever stand on one leg and scoot with the other. So it's reinforcing asymmetry, which is the last thing we want with exercise. Exercise should be symmetrical. It should be equally difficult on both sides. There is no point in exercising only the weak side. There is certainly no point in only exercising the strong side. So symmetrical, the same on both sides. That's where exercise should be directed. So we don't like scooters. We're not keen on trampolines and gymnastics because the children generally do not have the muscle power to save themselves, so you are at much greater risk of sprained ankles, sprained knees and wrists. So it's not a thing we like a lot. And the other thing we're not keen on is dance, and specifically ballet for the little girls, or any dance such as street that encourages going up on your toes. So if the girls want to dance, we like Bhangra dancing, we like tap dancing, and we like Irish dancing because they're generally done with a much flatter foot with more emphasis on the heel. So there's always a way around most things. Excuse me, I managed to come back from a week away with a cold. So those are some of the bad exercises. The other thing about bad exercise is it's boring. It's too easy or too hard. It's targeting the wrong muscle groups like those slings. So there's some of the spider webs that people are using, the elastic spider cages are becoming very popular in private practice. Unfortunately, the physiotherapists do not know which muscle groups they're necessarily targeting. And again, we're getting the wrong groups being exercised, which can increase contractures. So it's really important, if you're getting advice from your physio about the exercise that you're doing, that they know the groups that need exercising, the ones that need avoiding. So that's the main thing about bad exercise, and it's asymmetrical and it's fatiguing. Good exercise targets the right muscle groups. It's fun. It's not boring. It's the right level, but obviously needs to be progressed, and it's varied. It's aerobic. It gives you a high, which is what exercise is about, releasing your endorphins and feeling good. And it's symmetrical. So the activities that we like are generally the symmetrical ones. Swimming is undoubtedly one of the very best exercises you can do. Now we know in cold places, people do not like to swim in the winter. It's cold. Children get cold, adults get cold, and it's not a fun thing to do. If you can find a warmer pool, often in some of the hotels that have health clubs or private sports clubs, or often at a warmer environment, a hydrotherapy pool, I accept it is much easier to swim in these pools on a regular basis throughout the year. There is nothing that says with swimming that you have to wear a swimsuit or swim shorts or trunks. You can wear the all-over body suits, such as the Australian swim style suits. Some of the ethnic groups, some of the girls that wear the full body suits. There are a lot of body suits around for men now as well. And there is nothing to stop you wearing full body armor, not quite that heavy, but there is nothing to say you have to be totally undressed to swim. So if you're going to get cold, wear more. So swimming is one of the best exercises. We can take ventilated children into the water, but it has to be done on a one-to-one basis, and that is better in a hydrotherapy pool where you have the facilities around you. Now, if you're going to take a ventilated child into the water, you need a team who know what they're doing, but it can be done, and we can do it. Any physio team and some of the hospices will take ventilated children into the water, or ventilated. Doesn't have to be small children, it could even be ventilated adults with the right team. I have taken a fully ventilated 19-year-old into a hydrotherapy pool. Not impossible. Another exercise we really love is horse riding, for lots of reasons. The first thing is a child on a horse looks pretty similar to any other child on a horse. So it's something very positive. It's not something disabled. It's not something that other people aren't doing. It's a nice thing to do. Obviously, you are better off at a special riding school or with an instructor who understands the problems of disability, because you can get deeper saddles, you can get easier ways of getting onto the horse, and you should have somebody, certainly in SMA, if the child is weak, or the adult, if you're really adventurous. I have a 19-year-old who's still rides regularly. If you're adventurous, there should be somebody at least on one side of you, or if not on both. In some of the tinies, we have seen the children riding actually in front of someone on a deep saddle. So we really like horse riding. It's great for the core. I know not everybody likes horses. We do have children and adults who are allergic to horses. Horses are not my favorite animal. I'm not sure I would want to ride, but it is a great activity. We like boxing. We would say get some lightweight boxing gloves or sparring gloves that you get in the martial arts. These are not heavy, these are just foam. And you can get foam sparring gloves that are much lighter and go and box. Box your siblings, box a boxing ball, one of the things that hang up, hang down, the inflatable boxing things that you can get. And boxing is lovely and symmetrical. We like martial arts for the ambulant kids. The problem with martial arts generally is that it's very rare to find an instructor, a sensei, who is prepared to accept a child into a martial arts group. And that's unfortunate, because actually it's really lovely. I have done workshops for children in wheelchairs with martial arts. Our friend is a 6th Dan black belt karate expert, and we've set up fabulous workshops for the kids, even in wheelchairs, doing martial arts. So it's not impossible. And we know that there are a lot of sports out there: skiing, sailing, power chair football, wheelchair tennis. Table tennis is quite a nice one, because while it's not symmetrical, it's very lightweight and you're not using a lot of effort on one side. So we quite like table tennis. We like cycling. Not every child or adult can cycle, not everybody wants to. Tricycles are often more stable for some of the kids. There are now electric bicycles. That's cheating if you only use them. There are the low-geared bicycles. Beware. Low-geared bicycles are great, but they are extremely expensive. They cost around £4,000. They're very heavy, so they're not easily transportable, but they are a lovely way, if you have a family who likes cycling, to go out all together. Whiz Kids and some of the other charities will buy the low-geared tricycles. So there's many ideas just for sports and activities. Sport England have a whole website for disability sports. There is no excuse not to join in something. And Stoke Mandeville, the Spinal Injury Centre, they have a children's sports, I think it's even a weekend once a year, where the kids can go and try all these different sports. Admittedly, it's in Aylesbury. In Buckinghamshire, it's not accessible to everybody, but it's certainly something that those children who live in the south could access. Andy, should we take a break there before we actually go into the nitty-gritty?
Yeah, absolutely. Shall we go through some questions that have come in? Okay. Right. Andrea says, you recommended horse riding. Do you recommend horse riding for someone who cannot sit unassisted, e.g. wearing a spinal jacket and or someone holding him/her on the horse?
The issue of horse riding is more head control. There are riding schools that will take you riding for the disabled, who will take you with a spinal jacket. It really depends on the saddle rather than the horse, because you have to be able to sit in the saddle with your jacket on. Then you will need to discuss that with the riding school. But you must have a degree of head control. The other thing is, if you have had spinal surgery, certainly within a year, you will need to speak to your spinal surgeon. Most spinal surgeons say no horse riding for a year after spinal surgery.
Fair enough. Another question's coming from Han. Once contractures appear, I think in this case the knees, is there much that can be done, i.e. CCDs? I don't know what CCDs is, sorry.
CCDs are contracture control devices. Again, we are back to the concept of passive. CCDs are pieces of equipment go onto your knees, and they've got a ratchet lock at the knee, and you put them on and you can stretch and stretch and stretch tolerably. Again, there is no such thing in SMA or any neuromuscular condition as no pain, no gain. The child or adult should feel a stretch, but if there is pain, you will get more negative result than positive result. You must not cause pain. So you can use CCDs to stretch, but it is totally passive. CCDs will only do anything if you really work the muscles afterwards, and I mean really work. If you stretch using a CCD and gain 5, 10, 15 degrees of movement, what is going to hold that range? So you had a bent knee like this, you've got it much straighter, but all that movement that you gained is not controlled by the muscle. That's why you lost it in the first place. So you really need to actively work to control the range you have gained. Not easy. CCDs by themselves will stretch, but they won't maintain. Now, we have used CCDs for knees, but there comes a point at which they will stop working. You can possibly use them for 6 months, but after that, you will come to a block. And certainly, if you are not either standing or using CAFOs to maintain the range, or splinting or working, CCDs are passive and can stretch, but will not maintain that movement.
Okay, great, thank you. Another question from Kirsty and Neil. I'm going to read the whole thing out. It's fascinating listening to you, Marion, so I hope you don't mind all of my questions tonight. We are currently in hospital as my daughter, type 3, has undergone spinal surgery this week. What would be your top exercise tips for rebuilding her strength once she is home, please?
Okay, now spinal surgery, she is type 3, but it's not unheard of. The first thing you need to consider is when you are got a scoliosis, you are not as tall as you should be. You've got a curvature in your spine that shortens you. One of the most important things after spinal surgery is you're taller. And if you are used to putting your hands to your mouth when you are bent, when you are taller, you may find you can't reach your mouth anymore. So you need work on your arms. You really need to get those arms working one way or another, because your trunk is longer, so that your arms have got to be able to reach much further. The other thing that is often thrown, particularly in type 2, but occasionally in type 3, is the head. If you have quite a bad curvature of your spine, your head and neck follow that curvature. So when you're sitting straight, and you can do this when you look around a room of people, when you're sitting straight, your head will be quite straight. If you're sitting to the side, what happens is your head will try and stay straight. So although you can't actually see, I am sitting to the side, but my head is still straight. If then somebody comes and puts a rod in my spine, then my head is tilted in relation to my spine. So we need to work on the head and the head position after spinal surgery. Now we prefer, obviously, to try and work that head before spinal surgery to keep it mobile and to keep it strong. So if you've got surgery coming up, get that head moving. Now it may be that she feels uncomfortable around the top of the surgery and doesn't want to, but if she can start just gently pushing her head backwards into the pillow, maybe once she gets home, to try and strengthen those neck muscles. Also, as I say, she needs to work her arms. And the other thing that tends to happen after surgery is your tummy muscles start feeling very strange because you're stretched. And your tummy muscles have sort of been for quite a long time, and suddenly they're stretched and they don't always know what to do. So you can start working the tummy muscles just by trying to hold them and hold them still while you're talking. Singing's a great way of working the tummy muscles. Obviously, breathing exercises is a great one. Lots of games you can play for breathing exercises. You can get a straw. Must admit, I'm using a silicone straw, washable, comes with their own little brush to use them. Very environmentally friendly. They've got quite a big hole, silicone straws, so they're a little bit hard to suck. But lots of games you can play using straws, breathing, blowing exercises, which hopefully the physios in the hospital will show you. But these are the areas: arms, neck, tummy, and breathing exercises.
Brilliant. Hope that answers your question, Kirsty
If
and
not,
Neil.
and ask some more.
And Kirsty and Neil have just said that's exactly what's happened. My daughter's arms seem too weak to reach her mouth, so I'm having to lift her elbow for her to help her drink, brush her teeth, etc.
Yeah, no, it's a very, very common problem post-spinal surgery. So again, if there's parents or people out there pre-spinal surgery, that we have a new concept of prehabilitation with spinal surgery. If you're going to have it, get fit first. The better you go into surgery, the better you will come out of surgery. So people think, oh, they're having their spine done, don't need to do very much. On the contrary, if spinal surgery is coming up, get the work in first, and then it'll be easier afterwards. Those arms up, 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 head exercises, make sure that neck moves everywhere, and some tummy exercises as well to stop your tummy feeling very strange when it's being stretched.
Thank you, Kirsty and Neil, and wishing your daughter a speedy recovery. Do we want to carry on with?
Are there any more questions?
There's more coming in. Yeah, I wasn't sure if you wanted to carry on with those or move on to.
A little bit on exercise itself then.
Okay.
We need to do is work against resistance. So let's think first about the resistance of gravity. When you are relatively strong, you do not notice that gravity is there. It does. I do not think every time I lift my hand to my mouth, oh, I have to lift it against gravity. But as soon as you have to lift a leg up a stair, as soon as you have to lift your body up from a chair, you begin to notice that gravity has an effect on weakness. More importantly, many, many type 2 children and virtually all type 1 cannot lift the weight of their arms and legs against gravity without treatments. Now we know most children are on a treatment, certainly. The type 1s are virtually all on treatment. Many of the 2s and 3s are now going to be on treatments. But we have type 1s who can lift their legs now against gravity, but not their arms. We have type 2s who can certainly not lift the weight of their legs. And this is a problem because people assume if you cannot lift the weight of your arm, you cannot move it. And this is completely wrong. If you take the weight of the limb, if you lift it for the child, the infant, whoever, if you lift the weight of the limb, you can lift it with your hand, excuse me, or you can lift it using bands. I have some TheraBand here. This is the elastic. We can use it as a sling so that you can put your arm in. I think many of you will have seen this concept over a baby gym for babies, but even for adults, you can use a sling system. It doesn't have to be TheraBand. It could be a towel. It could be knicker elastic. It could be anything that takes the weight and allows you to move. It's a really important part that you allow a weak person, child, infant, to have the weight of the limb taken, and then they can move an incredible amount. Now you can do it sitting, you can do it lying on your back, you can do it lying on your side, and get a lot of exercise in. Never ever think that somebody cannot move just because they can't lift the weight of a limb. That doesn't mean trunk. Trunk is obviously enormous. Head is really heavy. The head is your heaviest part of your body. There are exercises you can do for your head, and we definitely mentioned these last time, something called PNF, proprioceptive neuromuscular facilitation, forget it, PNF. And that is where you say things like, you're trying to push the child's head, and what you're saying to them is, don't let me push you, don't let me push, don't let me pull you. Or you put your hand behind the head when they're lying down and say, push into the pillow. You can do it in sitting, where you've got their head and say, don't let me push you backwards, don't let me push you forwards. Lots of things you can do with the PNF style exercises. It's harder to use the TheraBand as a sling for the head. It's not comfortable, but it can be done using a towel. It can be done using a good old-fashioned sling, but you've got to find them. And I don't mean a sling that you use with a hoist. But when I trained, which is far too many years ago, and even some younger physios now know that there are head slings that you can get for exercise. Excuse me, I'm very tired. Okay, so the weakest people, the weakest children, the weakest infants can be exercised once you have taken the weight of the limb for them. Makes life much easier. Again, we don't want to exercise or over-exercise those muscles that bend the hip, bend the knee, point the toes down, and turn the hand down, bend the elbow. Turning the hand down, again, we need palm up, exercises, games, activities. Good old-fashioned pack of cards. Turning a pack of cards over. Go back to Snap. Get off your iPad, get off your phone, and go play Snap. All little activities. Play-Doh, what you can only do with Play-Doh. If you've never seen it, this is an interesting thing. It's Lego tape. Basically what it does is it's tape that sticks. You can unstick it. You can stick it on walls. You can stick it on wheelchairs. You can stick it on beds. You can stick it wherever you like. And you can play Lego. You can play Lego going up a wall. You can play Lego on your wheelchair. You can stick Lego on tape. So you can do that as an activity. You can make games up, what we use a lot. And anybody who has ever seen me at work will know what these are. Finger lights. They are wonderful. They are little. They are light. You can get them in lots of colors, but most of them only come in 4. But I have got through hundreds of finger lights with the type 1s and some of the weaker type 2s. What you can only do with a finger light stuck on your finger or your toes. All games, all fun, all activities. My favorite, simple pot of bubbles. You can play in standing in your CAFOs. You can play in lying. You can play in sitting. You can blow them. Nothing like, and don't think adults that you are immune to playing, because you're not. Because a lot of our teenagers who stand in CAFOs, our 3s who go into CAFOs, have to play bubbles because they do. Because it gets them off their iPad and their phone apart from anything. Balloons. These are from Tiger. They're very strange. They're supposed to be heart-shaped, but they actually can look like a pair of boobs. They're rather strange. But balloons make great toys. But not only do they make great toys. One of the things we did with a group of teenagers last year when I was at an SMA camp in Italy was we had a Pilates session with a group of teenage SMAs. We had a fantastic Pilates session using balloons. You can do an incredible amount exercising with a balloon. It takes a little bit of help. You need to know what groups you're trying to exercise. Pilates is definitely one of my favorite activities for parents, children, adults, teenagers. A lot of people don't like it. Partly because they don't know what it's all about. I have had so many people say to me, oh, I don't want to do Pilates, oh, don't like Pilates, and I've never tried it. Admittedly, it's hard work. And if you're a wheelchair user, it's very difficult to find a Pilates group for somebody who is a permanent wheelchair user. So unless you can find a personal Pilates instructor or get together with some people in your area and get a Pilates group going, it's going to be difficult. But it is one of the best forms of exercise you can do and really get a lot of benefit from it. But the kids worked hard, and they admitted they worked hard. And what was more impressive was they wanted to do it again. And we did a Pilates session for parents, and a lot of them found their own disuse atrophy and really didn't know exactly just how weak they were, particularly around the core and the spine, until we'd done some Pilates. And we know even one of our mummies who has recently been on Facebook with back and neck problems, parents and carers, you need to exercise. You need good muscles. You need to be able to exercise too. But we really, really do believe play, activity, sport, fun. You want to do hand exercises. You ever get chopsticks when you buy your sushi? You can do chopsticks with jelly beans. You can do chopsticks with cotton wool balls. I'm cheating. I've kept my chopsticks stuck together so it makes it much easier. But if you actually pull your chopsticks apart, you can play. You can play games with your toes. You can lift up cotton wool balls with your toes. You can lift them into buckets. You can lift them into cups. There is no end of activity. Christmas is the best time to put away those iPads and phones, get around the table and play. We really need to get back to physical play. For the type 3s, Twister, put it on your Christmas list. Boxing gloves, put them on your Christmas list. Think about what you can do. Even paper aeroplanes. There is no limit. These magnets, very easy. They're too heavy, take away the little balls, but they're not that heavy. What you can do with magnets, what you can do with Lego, what you can do with Playmobil. Even if you can't get the Lego to stick together, use a lot of Lego people. It's getting to the point where we need to go backwards. If you read the literature, there are a lot of depressed and unhappy teenagers, and it's all supposedly down to this electronic equipment. So let's make Christmas the time we get back to doing some exercise. Specific suggestions are hard over a webinar like this. I am happy to do programs, but somebody said to me last week, and I was away working last week, I wasn't away on holiday, don't often go on holiday, can you give me exercise programs? I said, no, I can't. I cannot give you an exercise program because they're totally individually done in our unit. Yes, we cut and paste, but yes, we do them individually for everybody. I'm going to do a little bit more about type 3 in a minute when Andy's told me what more questions come in.
Okay, yeah, we've got some more questions. So Jabber, apologies if I've pronounced that wrong. In a scoliosis patient of 4 years old, type 2, one side is less strong than the other. What exercises would we use daily?
Now, when you get scoliosis, you've got to remember that the spine is not just the spine. The spine has the arms hanging off at the top and the legs hanging off at the bottom and the head balanced in the middle at the top. So when you've got scoliosis, you need to stretch as much as possible, but you need to think about weight bearing through both arms. Games and activities. One of our favorite pieces of equipment for children these days is not a therapy ball, but a peanut. Now, if you're not sure what a peanut is, it's what it says. It's inflatable. It's usually lower than a ball. It's peanut shaped, which makes it more stable and easier to use. It's a really lovely piece of equipment. You can straddle, sit on it. You can sit across it. You can lie across it, lots and lots of equal weight bearing through arms, weight bearing through knees, lots of nice games to do over a peanut. And if I had a child with scoliosis, I think that's where I would be, is playing over a peanut. Now, it is difficult when head control is poor, and sometimes that makes a ball easier because it's easier to work with a ball. If you've got a ball and you're at an angle on the ball, you can work more easily with your head than you sometimes can with a peanut. So I would be looking at either a ball or a peanut for a child of that size with scoliosis.
Okay, great, thank you. Another question. Earlier you mentioned about pushing your head into a pillow when lying down for neck exercises. Someone here has asked, is there anything available that can take the weight of the head to help do neck exercises?
The slings, there are head slings. They're very hard to come by. To be honest, one of the big problems is having something to attach it to. So you can get a head sling, but where are you going to put it? You could, in theory, tie it to your hoist bar and do it that way. Some people have have hospital style beds that have the bar coming over the top, which is supposed to be to help pull you up on. You could hang something from that. To be honest, the easiest way of doing it is probably with a towel around the head and held by somebody above the towel. Now, it's possible that people could make slings. As I say, what you shouldn't use for a head sling is the TheraBand. It's really not very nice. It can catch your hair, and if the weight of your head is too heavy and it snaps back, you can get pinged in the face, which is not a good idea. So probably the best idea for a head sling would be to mock up a towel somehow. Now, the old-fashioned meat hooks, which are often used in those very fancy kitchens where you're hanging your pots and pans up, you can use meat hooks if you put rings through the sling or sew a towel up so that they have that, and then either a hanger or a meat hook and then hang it onto something. But you have to find somewhere to take the weight of the head. Possibly easier to have a parent or a carer hanging onto the towel for you.
Okay, awesome. We have a question from Amy. Hi Marion, you treated me when I was a youngster. I'm 30 years old now with type 2.
Amy.
I've recently developed numbness in my right leg, which has developed to chronic pain in my foot. It's from my position in my chair, but difficult to keep sitting straight as I lean on that side to type, etc. Any tips on helping improve this pain, as I feel it is getting worse?
Very often these pains are a sort of what we call occlusion. If you're sitting very much to one side, what happens is you are very flexed in that hip, and your blood vessels and nerves that run down the front of your hip, your femoral nerve, can get trapped. It's almost like a pins and needles, but it can become quite chronic. You can reduce the sensation and the power to that limb. It's undoubtedly true. It's very common in young adults who are sitting very much over one side. Unfortunately, you say you type that way. The best thing that you can do is look at your seating. Now, it's not easy when you're a young adult of 30, when you're used to doing something one way, to have a complete change, because it throws your whole balance, it throws your whole way of working. But I would be really, really tempted to look at what you're sitting on, because as I say, it probably is, as you are sitting over to that side, you are occluding the vessels that lead into that leg, and this becomes chronic. It's bad enough that the SMA means you're not getting enough nerve impulses. It's like anybody getting pins and needles from kneeling or being in the same position or resting on your hand. You know, you can get pins and needles on your hand. It's the same idea. You've got to look at your seating. You've got to get a better seat. You've got to try and avoid that pressure going through that hip. Now, you may need a molded seat, you may need better cushioning, but definitely look at your seating.
And presumably if that's affecting, say, the right-hand side because of the occlusion that you're talking about, presumably in time you'll start to get problems on the left-hand side as well.
Not necessarily, no. People are usually very asymmetrical in the way they sit. The better seating should bring you more to the middle, or at least allow a better position, even if it's just for that hip, to get more sensation, more blood flow, more nerve supply down into that leg.
Okay,
and you can get swollen on that side, as Amy says. You can get pins and needles in your feet, you can get a cold foot, the circulation can be affected, and it can cause pain and weakness. So definitely look at your seating and your sitting position. I know it's not as easy as it sounds, but this will not get better without something being done.
Okay, brilliant, thank you. Kirsty and Neil, what is your opinion of conductive education for SMA patients?
Okay, now there are many things I don't like, Bow, Bath and Voiter being two of them. So if you're doing either of those, give them up very fast. I actually like conductive education, strangely enough. I know it was developed for cerebral palsy. It was developed, for those of you who don't know, it's sometimes called PETO. It was developed by a guy called Andreas Peto in Hungary. And it was developed, I think, in the 40s or 50s, because in Hungary, if you couldn't walk, you could not go to school. And he developed this program of conductive education. And basically, it was called conductive education because the teachers were conductors. And it was a 24-hour program of repetitive movement, repetitive activity that taught children with cerebral palsy, in effect, to walk. And once they could walk, they could then go to school. But it's basically about motor learning. This is why the repetition. But it's not a bad treatment. It's about being in the upright position. It's about being in the extended position, and that is what we want. I have no problem with conductive education for SMA. I'm not sure it's going to do for children with SMA what it may do for children with cerebral palsy, but as a treatment, yes, fine, go for conductive education. If it's not working for your child, you can stop, but it's certainly not going to do any harm, and I actually like it. I think there are a lot of positives in it.
Brilliant. We've got questions coming in thick and fast now, Marion, so do you want to crack on with questions?
Yeah, let's go for questions because I think they sort of direct what we're talking about.
Okay, no problem. So we've got a question come in, and I'm going to kind of paraphrase the question, but essentially they're waiting for a new chair. They are also waiting for a backup, and I've got a 3-month wait potentially, and they won't do the seat until the person has had the backup, I guess, because their seating position may change.
What sort of age and difficulty we're talking, do you know?
It doesn't give me an age, but maybe if the person's listening, they could message in and let us know. What they are saying is that their left femur bone is basically in the middle of her bottom now. Her pummel doesn't work too well as her tummy is protruding, so I tie her leg to keep it out when sitting in her chair, and her shoulder and elbow is taking the full weight of her curve as she tries to sit up. She's 12 years old.
Okay. Firstly, there shouldn't be a pommel in SMA. You should never be sitting with a pommel. It's fine to have a little contour between the legs, but no child with SMA should have a pommel. We don't want the legs out to the side. When you have the legs out to the side, it pulls your hip one way. We know from what we were talking about last time, this iliotibial band gets tight. It pulls you out sideways. It's not something we want. We want the legs should always be parallel in the wheelchair. Now, there is an obsession, not so much in the UK, but in other countries, with having the legs in this position because supposedly it's better for the hips. Now, we know that many children with SMA2 and 1 have dislocated hips or subluxed hips or dysplastic hips. Okay, your hip joint is a ball and socket. So you have a ball and you have a socket, and it is developed as you learn to stand and walk. So when you're a toddler, an infant, sort of as you're learning to walk, the head of your femur has not developed into that nice ball, and your hip joint has not developed into that nice round socket until you get up and start standing and walking. Because our children don't get up and stand and walk, the joint does not develop as it should, and it slides either out or partially out, or it doesn't form properly. That's dysplastic. Subluxed means partially out or wiggles in and out, and subluxed means that femur, the top of the thigh bone, actually isn't in the joint at all. Now the thought is when babies are born with congenital dislocation of the hips, by keeping the hips outwards, the ball and socket joint will form better, and these babies will then have better hip joints when they start standing and walking. It does not work for neuromuscular conditions, particularly for non-ambulant, as you're not going to develop a hip joint just by sticking your legs out sideways. It's not weight bearing. The best thing you can do to try and develop a hip joint is get up on 2 legs. And that's why, again, we use CAFOs as much as possible. In the wheelchair, you do not want your legs splayed out sideways. It is not of any benefit at all. You need your legs both symmetrically pointing forwards straight, and they need to be level, and your feet need to be at 90 degrees on the foot plate. Your knees should be bent at 90 degrees with 2 fingers behind your knees and the seat, between the back of your knees and the seat, and your thighs should be flat. They shouldn't be stuck up in the air. They shouldn't be sliding downwards. To take the right weight, our thighs in sitting should be flat so that the back of your thigh is taking weight as well as your bottom. So it sounds as though this young lady is really having problems with her wheelchair. I'm assuming it's a she, could be a he. Really having problems with the wheelchair. We have lots of problems with wheelchairs, not only because people don't know how to sit children properly, but also because people do not understand SMA. It is imperative that this person gets a good wheelchair and good wheelchair seating and is well supported as soon as possible. But we do not want legs splayed out sideways, and we do not want pommels.
Okay, thank you. Hopefully that answers the question. I've got a question from Nicola. She starts by saying, this is really interesting, Marion, thank you. Her son, who's 10 years old, is starting to show signs of scoliosis. What exercise would you recommend? He is a strong type 2, good head control and upper body strength.
Now, just because you're strong doesn't mean you won't get scoliosis, and unfortunately what we find is some of the stronger type 2s actually get quite a lot of scoliosis. 10 is good age, and it obviously means that this has manifested itself later, which is positive, but 10 is also pre-puberty, and spines can disappear off sideways when the boys start going through puberty particularly. I would do a lot of this symmetrical weight bearing through arms if you can, weight bearing through his knees. Try and get things whereby you're keeping the shoulder power symmetrical, you're keeping the pelvis level. Anything, swimming's good. It's very hard to swim asymmetrically. You go round and round in circles. Again, really anything that'll stretch the trunk, that'll work the arms, that'll get the body moving. What's quite nice if he's 10 and quite strong is to work on a therapy ball, do what we call ball dancing, lots of work on his core, lots of work jiggling, throwing balls, sitting on a therapy ball, doing quite a lot of work. They can be lying with their legs up on the therapy ball, trying to get their core moving that way, nice and symmetrical, lift one leg, lift the other leg. There's a lot of ball work. You can find quite a lot of these sorts of exercise on the internet, But certainly we love ball dancing. We love therapy balls for a boy of that age he can be playing with some of his computer games, sitting on a therapy ball, doing lots of jiggling sideways, backwards and forwards, using his core, twisting, Pilates on a ball. Anybody who does Pilates will know they love balls in Pilates. Lots and lots of ball work would probably be good. Going over the ball, weight bearing on the ball, legs up in the air, one arm, one leg, all sorts of nice stuff you can be doing on a therapy ball. Make sure it's the right size, and also be careful about getting on and getting off it.
Okay, we've got another question from Nicole Smith. My daughter has a spinal brace which hasn't fitted properly since her gastrostomy. We are waiting for another referral for a new jacket, but she really wants to sit up now. Are there any suggestions on ways to sit without her slouching and causing her spine to get worse?
I must admit, if there's a problem with the jacket and the gastrostomy, I'm assuming either the tummy hole's not big enough, or the tummy hole's in the wrong position, or there is no tummy hole at all. So unfortunately, if the jacket's not working, that's quite difficult. There are solutions. If you chop at the jacket, it may work, but you need to be careful about doing any chopping of a jacket, because if they're going to use the same jacket which the company are going to adjust, then they will get a bit iffy about you chopping. If they're going to make her a brand new one, chop the hole. She shouldn't be waiting. An orthotic appointment shouldn't take more than a couple of weeks. Have a good complaint to your local service who are making the jacket and say, this is urgent. This is not acceptable. My daughter needs an appointment in the next available clinic. And don't tell me that's months. It's got to be now, because otherwise you're putting her at risk of spinal asymmetry. The other way of sitting is trying to build her up with towels, trying to build her up with cushions, trying to get her upright, but it's never as good as a jacket. So I would push to have that jacket. Do something with it as soon as possible. Again, if that can't be done, I would go to an OT and see if there's anything. There is something, there are something called Burnett body supports, and these are the beads, like a beanbag. You put them around, you sit in them, get yourself in a jolly good position, and then you suck the air out. So it's a vacuum mold on a beanbag sort of thing. Burnett body support systems, they may be able to get her one of those in the meantime. Somebody should be looking at getting her something like that until the jacket's sorted.
Brilliant, thank you. Another question from Gurkhan. Our physiotherapist favours, is it Vojta therapy?
Vojta,
okay.
Get the physio then.
Can you please make some comments about the therapy?
Vojta is totally inappropriate for SMA. It's totally inappropriate for most things, but it's completely inappropriate. It's probably Czech Vojta. It was developed for cerebral palsy. It's based around primitive reflexes. Nobody in Western Europe uses it. It's Poland, Czech Republic, Slovakia. Those sorts of countries still use it. It's primitive, it's not acceptable, the kids hate it, and it's doing nothing. So if you really can't find anybody else, if you're watching this from Czech Republic, it's a big problem, because certainly Vojta is the most common treatment over there. It's getting less, thankfully, in Poland, but certainly in Eastern Europe, Vojta is still popular. It's not appropriate in SMA.
So that's a no then.
Absolutely not. Absolutely. And that's an agreement throughout the UK because it's not used. It's an agreement actually through Western Europe. Nobody in Western Europe uses Vojta. It's an East European thing. Nobody likes it. The only therapists in the UK who use it are East European therapists.
Okay, fair enough. Nicole's come back to us. The person, the child is type 1, they cut the tummy hole twice and flared it. The physio have now said that she needs a new one altogether. Just a little bit.
They need to do it urgently. It's really unacceptable. If they've done it and it's not working, they need to do it urgently, but in the meantime, as I say, it may be that a molded seat or something they can do like a bonnet body support in the meantime to get her up. If she really wants to sit, the alternative is something called a squiggle seating system. And with squiggles, what you get is you get a pack full of all sorts of bits and pieces that all Velcro together. And it may be that some sort of squiggle seating system would work for her. We have used it in some of our type 1s because it's very flexible. It's tubes, it's little wedges, it's triangles, all sorts of things. And they may be able to seat her with a squiggles, exactly as it sounds, squiggles seating system until the jacket's sorted.
Perfect. Okay, so another question. To strengthen abdominal muscles, particularly lower abs, which exercises would you recommend? The exercises I asked for a patient who cannot lift his leg upwards while laying.
Okay, so lower abs is an interesting one that somebody's asked for lower abs because not many people split their abs up. If you really want some abs work, go to Pilates. Pilates love abs work. Excuse me. You do not have to be able to lift your leg up to be able to do abs work. There are hundreds of ways of doing abs work. Lower abs are quite difficult. Now, this sounds like a male. Ladies find it easier. There is a lot of pelvic tilting work that will work your lower abs. Basically, you lie with your knees bent up, which is not difficult for most of our SMAs. It depends on whether you've had spinal surgery. In spinal surgery, it's much, much harder to get your lower abs switched on. If you haven't had spinal surgery, what you are trying to do is flatten the arch of your spine. What you do is you're lying down, you are knees bent up, and you are trying to tilt your pelvis backwards to flatten that arch. And sometimes it's easier if you put your own hands in or somebody else puts a hand in and can feel the pelvis rolling backwards. The muscles that pull the pelvis backwards doing that are your lower abs. And that is a good place to start. The other thing you need to do is actually find out where your lower abs are. You can do that. Your lower abs also connect inside the pelvis. So ladies find it easier to sort of suck up inside. Men have to learn how to do it. Something women are always taught, men aren't, is to actually suck up all their organs as though they're trying to pull all their lower intestines and everything, their bladder up towards their diaphragm. Suck up your bum cheeks, suck up your bum muscles, and try and find where your abs attach. Now, the other thing that you can do to try and work those abs, again, if you haven't had spinal surgery, it's easier, is to do things like try and keep your pelvis still and roll your legs together side to side, lie on your side and try a bit of clam work, where you've got one leg on top of the other and you're lifting your legs open. Generally, as I say, try and roll your legs side to side, keeping your pelvis as still as possible. So there are several ways of getting those lower abs. You can try putting something under your legs, lying flat, putting something under your legs and squeeze as though you're trying to lift your body up, like trying to lift your bottom up, and you will also get lower abs doing that.
Awesome. Okay. Another question. For non-ambulatory SMA type 3A, how can we do taking steps exercises? The patient should not bear weight because of the possibility of bone fractures, etc. CAFO, AFO not suitable now, again because of bone fracture risk.
Okay, now the problem is a bit of chicken and egg. If you don't weight bear, your bones get thinner. If your bones get thinner, you're going to fracture. So the problem then becomes a bit circular. If you can't use CAFOs, AFOs because you're going to fracture, then you're going to fracture because you can't use CAFOs, AFOs. So the first thing you could possibly use is to start with a vibrating plate and see if that will help. It's got to be very gentle. What you need to do is get your feet on the floor somehow, whether it be with a very low bed or whether it be with that it's possible in the wheelchair, or bring a box up to the wheelchair and put that, take the foot plates out the way and get a box there. Swing yourself right to the edge so that you're weight bearing, and try pushing down through your feet onto the box, onto whatever. It could be that you're pushing onto something squishy. It could be the cat. It could be whoever. Cats always sound like you go on to squash. I'm more of a dog person myself. I'm not sure our dog would let us do it. Might. Maybe I should try. But actually starting by pushing through your feet, almost as though you were doing that thing where you're trying to stand up. The other thing you can do is in lying, is actually get your feet squished down to the edge of the bed, so that you've got, if you've got a bed board, if you haven't, if you've got a divan and there's nothing at the bottom, you may have to swivel around till you've got the wall and push against the wall. You could push against a therapy ball. So you could be lying on your back with a therapy ball against a wall or even against a person and pushing into the ball. So although you're not weight bearing, you're getting weight through your feet and your legs. So there are ways of doing it that would get weight through your feet and your legs as a starter. But as I say, the other thing you could possibly do is get yourself either onto the floor or forwards with your feet on a very gently vibrating plate, as well as trying to push down and get weight through your feet, or do it in lying.
Okay, someone else asked about the vibrator plates while using orthotics, so that is a good move.
Well, the theory is that vibrating plates for people who don't walk would help with bone density, because it's the vibration of taking steps that actually helps your bone density rather than just static standing. So the current theory, and I'm sure it'll change in the next 5 years, is that standing or weight bearing with vibration is better for your bone health. This is not necessarily going to strengthen muscle. There are gymnasium that have these shaky things where you're supposed to exercise. My personal feeling is, having used these machines, it's more about the balance and fine muscle activity it takes to work against the shake. That's quite difficult for somebody who's very weak, is to actually work against this vibration. And it's not little vibration. We're talking about fairly big when it's exercise. So it's very much about fine muscle control on vibration, and that's difficult when you haven't even got large muscle control. But certainly in terms of weight bearing, it is supposed to be better for your bone density to use vibrating plates.
Excellent. So I'm going to combine two questions here. So Amy has come back and said, thank you so much for your response and all your help over the years. You are brilliant. So there you go. 5 stars.
Come back and let me beat you up again.
So Amy has asked, what are your thoughts on diet in terms of strength for type 2? I've recently become vegan, but don't want to affect my strength and joints. And someone else has asked, I'm overweight and nothing I do gets my weight to burn or not gets my weight racing. I assume they mean heart racing, to burn calories. I'm a full-time wheelchair user. So I wondered whether or not you could offer thoughts on those two things.
Now, when it comes to diet and veganism, I am not the best person to ask, because that is information you need from a dietitian. In terms of calorie intake and calorie need, I know we have now with us at Great Ormond Street a new consultant from Italy, and there is more and more work coming out on body composition in SMA as not being the same as body composition in normal equivalent. So if you're a 5-year-old, 10-year-old, whatever, your body composition having SMA is not the same as it would be in your equivalent normal. Excuse me. What the difference that makes in terms of your intake, I do not know. That, as I say, there is work coming out on this, but your body composition, unfortunately, as we know, there are not enough dietitians who specialize in SMA. I know where you live, Amy. I would possibly go to Addenbrooke's and see if they've got somebody in their adult service. But we do need to find good adult dietitians with an understanding of SMA. It may not even be in this country, and work on this idea that your body composition is not the same, and therefore what your intake is, what you need in terms of proteins, particularly because protein is always the thing that people complain about in veganism, that you're not getting enough of the right proteins. So to be honest, I am not the right person to answer that. You really need to talk to a good dietitian. In terms of burning calories, very, very difficult, but not impossible. I think what you need to find, and you're obviously an adult asking this question, is what is it that you can do to work? What position? You're a full-time wheelchair user. It may well be that being in the wheelchair is not the place you should be doing work. It should be on your bed in the morning before you get out, in the evening before, even trying to roll in the bed. Very, very difficult, but not impossible. Now people say, oh, I can't roll over in bed. Fine, you can't, but that doesn't mean you can't try and roll over, or somebody can't help you in part of it and you do another part of the movement. That you can't use TheraBand, you can't use weights, you can't. Everybody can do something. It's just finding what works for you in the right position. It may be that you work better inside lying. It may be better that you work better with your legs up on a ball. It may be sometimes actually having a one-to-one therapy, using something like PNF to push you, to pull you, static work. I could make you work hard and you would feel it, but you may need somebody to help you do that. I was working last week. I had a young man of 28 with an unspecified limb girdle dystrophy. We got him on the bed, he's non-ambulant, and we worked him hard. And he said, I'm sweating. And he said he has not worked that hard for a long time. And it was just finding what he could do and really pushing him to do it. So it's not impossible, but I appreciate it's really hard. You really don't know unless you get some help to do that, to find out. And it doesn't have to be a physio, it could be a personal trainer.
Awesome. Okay. And Amy, if you're still listening, we might see if we can find a good dietitian prepared to come on and do a webinar at some point. That might be quite popular. So we'll see what we can do. I've got another question. My type 3 has just lost the ability to walk in the last 2 years. What can I do to help encourage this back, or at least maintain what is left in terms of exercise?
I'll be very honest and say, if it was at GOSH, they'd be in CAFOs, depending on their age and whether they wanted to do it. But we are very keen to keep our threes mobile. It's a very, very difficult time for these threes, because if it's more than a year, you don't get the spin rasa. I'm devastated more than anybody. I know I'm not a type 3, I don't have a child with type 3, but to me, I really do believe there are a lot of threes out there who've lost ambulation maybe more than a year ago, who could do amazing things with some of these drugs. So I really will be at the forefront of pushing for these type 3s to get it. But we need to keep them contracture free. We need to keep them as strong as possible. If it's not Spinraza, it could be Risdiplam, it could be Novartis, the Avexis. We don't know, but get whoever it is standing, doing as much as possible. Keep them as strong as possible. Drugs are on their way. I want these kids back on their feet. CAFOs, gaiters, standing frames, exercise, swimming, sport. Get them motivated. Make them understand how important it is to try and keep those amazing muscles going.
Another question, just a general question really. Is there a demonstration video of exercises that you know of?
The problem is there isn't, and people have said to me, why don't you make one? I can't, because we tailor all our programs to individual children and families, and knowing what the child likes, where their weakness is, where their contractures are, what will work for that particular child. Knowing personality always helps. So we can talk about exercises there. You can, if you get back to the TheraBand idea, we do use a lot of TheraBand, a lot of TheraBand. This is cream TheraBand. It is not commercially available. I think at GOS we get through more cream TheraBand than anybody else in the country put together. It's very light resistance. It's very easy to stretch. As I say, it's not commercially available. It is TheraBand and can only be got from TheraBand. We've seen nasty cheap versions, and the cream cannot be got from any other company. So that is TheraBand. But there is a lot of this elastic band out there. Tiger often sell it. All these places sell it. And if you go onto the TheraBand website, there is a whole list of TheraBand exercises in a booklet form, free, gratis. You can download it and get some ideas of things to do with TheraBand for definite. Excuse me.
Awesome. And if you do want to do an exercise video, Marion, then TreatSMA are more than happy to help.
Oh my God, I'm not getting that. The problem, as I say, is it's easy to say and very, very hard to do, because if you think about even the questions that have come in tonight, they are so varied and so different from person to person that it would be almost impossible to do a single exercise program. It would not be impossible to look at putting together ideas for the groups of muscles and the way to do it. That may well be something that we could do. I was asked a long time ago by what is now SMA UK to write a book, and once I wrote it, they did say to me, oh, sorry, it's much bigger than we expected, we can't publish that. So I may well be able to go and dig that out and find that actually there's an incredible amount in there on exercise that we may be able to put something together.
That's brilliant. If you can find it, we'll certainly have a look at that.
Oh, certainly around.
Brilliant. Another question, would massage help with contractures, or could it cause damage?
Massage can't cause any damage. To be perfectly honest, who is going to benefit from massage? Parents and carers. I think every parent and every carer should have a regular massage. I think that's an essential. I think it should be on the NHS. I think it's wonderful. I hate it, but that's me. We had to train in massage at Physio school. I don't think they do it now. And so I got used to massaging, which is fine. I do it at the London Marathon. We use it for cramp. We use it for warming muscles. But in terms, no, you certainly can't damage, not unless you're very strange at what you're doing. But again, it's passive. It warms the muscle up. That's something that we should mention, which I will in a second. But it's not going to, again, it's back to passive. It's not going to do anything but warm the muscle up before you then need to exercise it. Now, if any of you, be parent, carer, person with SMA, or whatever, if you are stretching before exercise, stop now. Now that is you when you go to the gym as a parent or carer, or if you think that stretching before you exercise your child or yourself is going to help, it is not. You do not ever stretch cold muscle. So yes, massage helps, yes, warm helps, yes, getting the muscle moving gently and then making it more vigorous, but do not stretch cold muscle. You are much more likely to damage it, and you are also going to get less stretch. Warm muscle stretch is better.
Great. Right, last couple of questions. This is from Bogdana. Do you have any advice for exercises in hydrotherapy for SMA type 3, 6-year-old ambulant? Do you recommend hippotherapy, horse riding for SMA type 3? So happy to hear you again. Hope to see you soon in Romania.
Hippotherapy and horse riding are not the same thing. A hippotherapist would be very miffed if you said horse riding. Hippotherapy is specifically exercise on a horse, whereas horse riding is an enjoyable activity where you're literally riding a horse. So hippotherapy, if you're a hippotherapist, is not the same as horse riding. It's a bit like saying hydrotherapy and swimming are the same. In theory, they're not. Hydrotherapy, yes, are very definitely things that you should be doing in the water for a type 3. Again, firstly, it's got to be fun. Secondly, it's got to be exercising the right groups. And thirdly, and really importantly, when it comes to swimming, for anyone with SMA, what you do not see is sweating in the water. You don't sweat in the water. You do actually, but you don't, in as much as you can't see it because it gets washed away. So the most important thing to be aware of for a type 3 in the water is fatigue. And this is really, really important, because I know for a fact a young man with type 3 that we see, who is a really wonderful swimmer, who rushes into the pool and struggles to come out. And that is swimming a little bit too much. You need to be able to actually pace yourself in the water and not overdo it. Having said that, we do actually work our type 3s quite hard in the water. And what you are looking for is to make sure you are not using hip flexors, you are not using knee flexors, and you are not pointing your feet down all the time. Now, what we do is we play games in the water. And if you want to play games, you run backwards because that uses your butt muscles. You run sideways because that uses your hip abductors, the ones that lift out to the side. So if you concentrate on muscles that lift your leg up backwards, getting your legs flat in the water, if you're on your tummy, swimming with a straight leg, we do, I'm very cruel, and I put armbands around ankles, and we do exercises doing that. Lots of what we call abduction, which is legs out to the side one way or another against resistance. Lots and lots of abduction. You can do core in the water. You can do quite a lot of bottom muscle working. What you have to be aware of is that sometimes the water helps too much and makes the exercise too easy. But as I say, it's abduction, hip extension, knee extension. Those are the things we're after in the water, along with tummy and obviously arms.
Brilliant. Okay, last question. Best exercise to encourage kneeling. My daughter started treatment aged 4.
Kneeling.
Yes.
Okay, now the problem with kneeling is it can overuse hamstrings if you're not doing it properly. What you need with kneeling is to make sure your bottom is tucked in and your weight, your spine is nice and straight. Kneeling is great if it's done properly. Again, we do it at a ball or we do it at a peanut. A 4-year-old, you can use a peanut, kneel at a peanut, go over the peanut, come back again. You can do kneel walking. What you need to be aware of is symmetry, that they're weight bearing equally, that their bottom is level, and they're not over extending their back. Now, if they've got tight hips, they'll have that big arch in their spine. Their lordosis will be increased. So you need to make sure that they're not either lordosed or flexed forward, that they're in nice alignment doing that. It's a lot of butt muscle. We like it. We like kneeling as a position, as long as they're not overusing hamstring to do it, pulling their knees up. You sometimes find the kids are actually getting their feet up towards their bottom. Their feet should be staying on the floor and their bottom should be nice. It shouldn't be, you shouldn't be, have your pelvis rolling forwards, and try and avoid that big arch in the spine.
Brilliant. Okay. Well, I think that's all of the questions. If we missed any questions, then please do email either myself or Lucy or TreatSMA directly. Pop any comments in the post. I just want to read one more comment. There's loads of thank you messages coming in, Marion, throughout the session, but I'll just read this one from Kirsty and Neil. Marion, you make so much sense and you're amazing at making suggestions which are simple but so effective. You help us as parents feel empowered to battle the system. There are so many professionals out there who are fantastic but have no clue about the ins and outs of SMA. Thank you so much for your brilliant advice. Which I think
on that one, Neil, that ultimately what I have to say is thank you to all the parents, to the Amy's of the world who were around when I was not very much of an expert, who put up with me beating them up, who I possibly wasn't as experienced as I am now. But the people that have taught me what I know have been parents and kids. So I can only say thank you to them. We're meeting again between Christmas and New Year, so everybody will be really ready to do some exercise again then. But we are looking at the topics of spine and posture. I'm quite happy to talk again about contractures and exercise, but the topic next time will be spines and posture. So that's where we will be going next time.
Brilliant. Thank you to you, Marion. Thank you also to Lucy.
Thank you, Andy, for all your help.
And Lucy, who's been helping in the background. So thank you, everybody.
To Lucy as well.
All right, you take care, Marion. Thanks very much.
Thanks, Andy. Bye.
Bye-bye.